Welcome to the Class Insights podcast. Today's conversation is with Donna Roach, CIO of University of Utah Health. In our conversation today, we focus on the expansion of virtual care beyond what we learned during the COVID-19 pandemic. We hit on artificial intelligence and how that can be used to improve consumer-centered experiences. And we also talk about the hospital of the future that the University of Utah is developing. We hope you enjoy today's conversation. All right, welcome everyone to today's episode of the Class Research Podcast. This season, we're focusing mostly on emerging technology, and I'm joined today by Donna Roach, the CIO from the University of Utah. Donna, welcome to the podcast.
Thank you. It's great to be here.
Yeah, Donna, so Donna's done a lot with Class. Most recently, she helped us with the Emerging Solutions Top 20 report, which was the first of that report that we've ever done. And we'll get into that a little bit. But Donna, could you just maybe tell us a little bit about how you arrived at the University of Utah in your current role?
Sure. Yeah, happy to. So I actually I hail more from the Midwest, but if I kind of reverse my trajectory, I came here from BJC and WashU Medical School. And then prior to that, I was with Ascension for about 7 years. So Ascension is corporately headquarters in St. Louis. But before I got to the corporate office, I was in Pensacola, the Gulf Coast market. I was in Wichita, Kansas, which was via Christie. Before that, I was up in Michigan, up at Borges, and then I took on the New York hospital. So kind of learned quite a bit within my Ascension role as CIO. Before that, I was with Resurrection, Advocate, Central DuPage Hospital, Rush. I've been in healthcare IT my entire career. Absolutely love it. I have a bachelor's and a master's in health administration with a very heavy focus on systems and IT. So I come out of the more of the understanding healthcare and then layered in some of the IT, kind of background. So always exciting. I can marry the two, healthcare and IT together, and it's really an exciting career.
Yeah, that's great. And so why healthcare? Why technology? Was that something you were always been interested in, or where did that kind of come into play?
Yeah, so I have a lot of family members that have been in the healthcare side of things and kind of ushered me a little bit from a schooling side. I have a strong STEM background, but they're like, oh, you need to think about healthcare as, your career choice. The further I got into that, it was like I'm a very logical kind of thinker. And so kind of marrying the IT with the healthcare was probably a better combination for me. I went to school at the University of Illinois in Urbana, so Osceola, and had to actually create my own health administration program. And with that, I put a lot of IT into it. Now they actually have a health administration undergrad. And my dean that helped me establish that program basically said, listen, if you're going to go anywhere with this kind of degree, you need a master's. So I looked at different master's programs. Rush was my choice. And I liked Rush because they have a teacher practitioner model. So we would go to school. We would work in the morning, and then we would go to school in the afternoon. And I just learned a tremendous amount. I had a lot of great mentors who basically said, you think in a very logical kind of IT way, and kind of encouraged me to get into that side of things. Wayne Menning, who he ended up being the CIO at Mayo, was kind of one of my early mentors, and kind of said, hey, think about getting into IT. And in the beginning, I was like, I look at what you guys do. It's very politically charged. And it's like, I don't know if I want to do that. I'd rather just do the work. And he's like, no, give it a chance. And so I would say I actually fell into the CIO role more than I purposely chose the CIO role, but really have enjoyed it. I like the strategy part. I like being able to project out how best to use systems, but also to understand the people in the process. I mean, in IT, we talk about people, process, technology. Technology is actually the easier part. It's the people and the process that are more difficult, and you have to go into it respecting that in order to make the technology work, it's all dependent on those people and those processes that you help establish.
That's really interesting. One of the principles we kind of teach or have found at class when working with all the vendors that we work with is obviously the technology is important, but relationships are such a big part of that. Because a lot of the technology, especially nowadays, can do what it says it can do more or less, right? But without the people, the training, the respect for what's been done in the past and what needs to be done in the future, it's really hard to make that technology work unless you know how to kind of play that game and juggle all those balls and keep them all in the air.
Yeah. And I think, most people bring a certain knowledge to the table, but it's really a slice of the pie. And what I tend to do is I look at the whole kind of pie and figure out how do I bring it all together. And it's funny, sometimes you'll have somebody who is so has such a great background and has a very deep understanding of something, but they don't have the full picture, and you've got to bring them along in order so that they can contribute effectively without kind of overtaking the whole process. And I tend to do that. I like bringing those different pieces to the table. It makes it more difficult at times, though, because when you have a lot of voices, even when you think about setting up governance, you have a lot of voices at the table, but you have to show kind of progress, and you have to show, here's our overall goal. Here's where we're directed. I appreciate all the voices, but at the end of the day, we're going to go in one direction, not in multiple directions. Yeah. And so it's just a good, when that works, it really feels good. And people feel that they're contributing, but they're also contributing to the direction that we've set, rather than just individually everybody contributing, and then it kind of gets all mixed up. It's more, it's not a stew, it's a pie, right?
So one thing that kind of I want to ask you about this before we jump into some of the areas of technology that you kind of find interesting and maybe most exciting. But before we started recording, you mentioned between your career, which you kind of already mentioned, you've been at a lot of different places, and growing up, have had 40 addresses in your life.
Right.
How has that maybe contributed to your ability to kind of make that pie that you talked about and put things together? Yeah. Talk about that for a second if you can.
Yeah. So I think what it's taught me is, one, to be kind of humble and go into different situations doing a lot of listening rather than being very forceful about what my opinion is. I learned early on how to, I wanted to make friends, like to come into a new situation and feel really comfortable in that situation very quickly, and kind of keep those relationships going. There are people that I have known throughout my career that I can still reach out to and still kind of have a really good dialogue with, or kind of tap them and say, hey, can you help me out? And that's because I early on, I created that relationship with them, but also that I care about them as a person and what they're contributing and what they're doing. So I think it's created in me kind of this way to be understanding when you come into a new situation, but also humble and a lot of times giving people grace. Like, people have bad days, right? And you see, I've seen it all across the board, and you don't want, I don't allow a person to, in my mind, when they're contributing their idea, I don't think about, well, you had that bad day, so that's how I'm going to treat you. I'm going to treat you more as, okay, you really know what you're talking about, and I know you can contribute in a real positive way. I have been in all different areas of the United States. And, people are all kind of the same. They want to be heard, but they also want to be respected. for what they know and how they can be part of a team. And so you just you work with and you fit into an organization in the right way. And as a contributor, either you are sometimes the leader or sometimes you're the follower. And I think you have to be really comfortable in both situations.
No, I love that. And we came to talk about technology, and we've gotten a bonus lesson on leadership. So I appreciate you sharing your experience.
Yeah.
This is incredibly helpful. I hope our listeners find it helpful as well, because I've learned a lot myself. So appreciate you sharing all that. Well, you've been a CIO during a very interesting time. I mean, obviously there's been so much development just with the technology, and then you talk about legislation that has pushed things forward or forced certain changes. Implementation of certain things. I want to get into so I mentioned it earlier in the podcast. You contributed to our first Emerging Solutions Top 20 report. And just to give quick context to our listeners who may not be familiar, CLAS writes these Emerging Solutions reports on newer technologies. We do those throughout the year. And we had a group of CIOs and other C-level healthcare executives read a bunch of those reports. There were about 42 total, I think, and we split them up into two groups. We had, so this group read these reports and then rate them based on rate the solutions in the reports based on their potential to impact healthcare in the 4 areas of the quadruple aim. And from those rankings, we were able to compile our top 20. And so if you're interested, please go to the CLAS website, look up that report. It's the Emerging Solutions Top 20 report. There's a lot of great stuff in there. And one of the things that we asked those that contributed to the report to do, if they so chose, was to write about what they're most excited about and what trends they're seeing in healthcare information technology. And Donna wrote some great stuff, and we want to get into that today and go a little bit deeper. And so just to jump right in, the first thing you wrote about was expanding virtual care.
Right.
Obviously, we've seen a lot of changes with that since the onset of COVID. But why do you feel like expanding virtual care is so important? Why is that a crucial thing in healthcare right now?
So virtual care was something we all experienced through COVID, and so not very innovative, right? We all had to pivot very quickly. We all had to go from 0 to 40,000 visits a month. We all did that. I think where I would call it more innovative, especially in the academic environment for the University of Utah, is you have to now culturally make it fit appropriately for the conditions and for the patient and for the physician. So you talked about the quadruple aim. We apply a lot of experience. So what's the total experience that somebody is encountering when they have a virtual care visit? That is really helping us to drive the innovation in this space. And interestingly enough, we've spent a lot of time looking at where has virtual care accelerated versus where has it kind of not done so well in our environment. And one area that really surprised me is in GI. We do a lot of virtual care visits in GI, and mainly because we have a leader, one of our chairs, helping to drive and set that culture of saying, yes, virtual care will be an option for us. And so a lot of the preparatory work and a lot of the follow-up is done virtually. But go back to that people, process, and technology. The innovation is more in the people and the process, not necessarily the technology. Now, we've improved on the technology of virtual care, and we'll continue to do it. Sure. Because we want the best experience for our patients, but also our clinicians. We want them to feel that they're doing the right level of care in this kind of new environment.
So one of the things you wrote about, you said patients no longer want to take time off work, drive to an appointment, and wait in waiting rooms just to spend 15 minutes with their practitioner, right? When they could maybe just go into their office at work, or if they're working from home, they just stay home and have that visit. Obviously, not everything can be done virtually, but a lot can. And so, how do you see the patient benefiting from this? Are we seeing more patients? Is this an expectation now is this a way, are patients going to be seen more because they're more comfortable doing this? How do you see this benefiting patients?
Yeah, we do surveys of our patient population, and there is an expectation that this is going to continue even past COVID, right? They're thinking exactly what I wrote about is, I don't want to drive up the hill, because that's the actual location of Utah
Sure.
Health is up the hill, to then have to park and then have only see my physician or the clinician for about 5 to 10 minutes. If they can do that follow-up, they want to be able to do it in the comfort of their home or even in their office. So we look at that feedback from the patients and incorporate that in how we are doing our improvements. So we will give that feedback back to the service provider or to the clinician to say, here's what we're hearing. Continue to provide these services. So in thinking about process, the physicians then have to open up their schedules a little bit more to these virtual visits, rather than closing it off and saying, nope, only in-person visits. And it was really, there was a point at which we had to pivot, and there was a big push to say, nope, let's bring them all back on site. And it's like, no, the feedback we're getting from the surveys is saying, keep doing these virtual visits, but also, be comprehensive in the sense of knowing when I do need to come into the office, or I do need to have that in-person visit. I will still do that, but where it's just a follow-up, or you're just doing like a med check or something, that can all be done virtually. And so it's incorporating the feedback process into how we're doing our process redesign.
Interesting. So I would imagine people are probably more likely to do those follow-ups if they can do it virtually.
Yes.
And then the other question I had, this is an area of interest, personally, is just with health equity. Like, has this allowed you, or do you and maybe anticipate allowing you to reach patients that maybe you couldn't reach before, whether that's because they live too far away, or they lack transportation, or just, it's like all these social determinants of health that we talk about that maybe limited their ability to get care, but now this maybe opens up new doors.
Yeah, I'll give you a really good example that we were surprised about. We had, we're an Epic shop, and we have MyChart, and we're fairly extensive in our rollout of MyChart, but we held off on doing MyChart in Spanish, and for a real specific purpose. We didn't see it as just a switch that you could flip and turn it on, and all of a sudden, it's all in a Spanish language that, and in the proper dialect that the Spanish population, right? So we went through, we were very purposeful about turning it on, mainly because we wanted the communication to go two ways. So if I'm a Spanish-speaking patient, I can message my physician, and then my physician or the office is messaging me back in Spanish. And we wanted to be able to have that good dialogue that would occur. We also wanted the comfort level too with that, it's dialect issues have to be incorporated into our clinical workflows appropriately. And so we wanted to make sure that was correct. And then we also wanted to make sure in situations where somebody does still want a translator, that we're having that capability. So we had to build a lot into it, and we delayed our MyChart for Spanish for a good, maybe 12 months. But when we did turn it on, we thought, okay, this is in a better format, and it's probably a little bit slower process, but we're going to do it in a very purposeful way. What we were surprised about was how, and we didn't expect the usage rate that we saw. And I don't have the exact numbers in front of me,
Sure,
but we doubled and tripled our usage rate to the point where it was like, whoa, wait a minute, we have to incorporate more capabilities now in the Spanish in MyChart than what we had planned. The other thing we saw was And I think this was really very telltale, that there are people like using the MyChart for Spanish versus a translator because they felt it was more private than the translation services. So that also saw a big uptick in the usage rate, which wasn't what we expected. We thought, well, wait a minute, have we kind of had our own kind of bias of saying, well, that the Spanish-speaking population may not want to use it? It was actually they wanted to use it more so than having a translation service because they felt it was more private if it was more computerized, which was something we never even thought about. And then when we started doing a little bit of research, we're like, there's research out there that specifically talks about that kind of increase in access because of the privacy concerns. And I'm like, that was fascinating for us. And we really saw just a huge uptick in our use of MyChart for Spanish. And we didn't even market it, and it took off. So now we're doing a little bit more marketing campaigns so people are aware that we have the capability. So yeah, it was kind of it was one of a little bit of a surprise, but really welcomed, I think, in our community, that it was an outreach that we had never done before. And now that we're serving a population in the language that they're comfortable in, rather than kind of forcing a different kind of, kind of process that may be a little more uncomfortable for them.
Well, I think that's a great example of how a couple things, when you can meet people where they're at and give them an experience where they're comfortable, whether that's with language, or I would imagine there's others with whether that's, their socioeconomic status, race, gender, sexuality, all those things. If you can help people feel comfortable, they're more likely to take advantage of those tools. And then the technology just helps you reach more people.
Right. The other thing I'll add is, we're a very data-driven organization. So we look at the data all the time, right? Mm-hmm. And I think here's what I love about the University of Utah Health is when we looked at even our vaccination rate, we could see disparities. So we're putting things in place to try to correct some of the disparities. But if you never measure it and you don't go back and you look at it, you really don't know kind of what your baseline is and how to improve. And so we're always in that improvement process. And it's not a blame game, right? It's really, okay, we didn't do so well in our outreach of vaccination or our outreach in testing, but now how can we improve upon it? Because we have the data to show it. And so now we track on it on a regular basis.
Oh, I love it. Yeah. I mean, the data helps inform what steps you take, right? And where you move forward and how you can reach more people. I love it. Well, let's move on. We've got several other topics to cover. I want to hit on at least most of them if we can. So ease of access, and I guess we've talked about that a little bit with virtual care. But one of the things you mentioned was, at the University of Utah, we plan to leverage artificial intelligence and machine learning technology to enable consumer-centered experiences and orchestrate care. And I underlined the consumer-centered experiences. Maybe if you just talk about kind of what you mean by that and how you can move forward with that. What does that mean for you and the University of Utah?
Yeah, I think one of the things early on when we started to look at even our digital strategy and how we were going to bring a greater awareness of the kind of consumer experience into the strategy, it was taking a step back and saying, hey, I can thread experience throughout all my initiatives, but we actually have our own, we call it kind of a swim lane of total experience. And when I talk about total experience, it's taking not just the clinician experience or in the patient experience, but also the employee. And so it's that combination of all three of those things that really make up how we will gauge the experience of our systems and our digital strategy. And, I think it becomes one of the ways I've tried to explain to people, it's, you can do initiatives and you can do outreach. Like I can do virtual care and really improve upon the patient experience in virtual care. But if I do it at the expense of the clinician, that initiative is really going to be short-lived. So part of our design is to look at the full experience. The thing I was going to mention is, as we look at journey mapping, we take into account all the different experience points and making sure that we're not doing one at the kind of the expense of the other. And that's hard. That's not easy stuff. And so we recently have partnered with Qualtrics to do not only our employee survey process, but also our patient survey process. And our director of experience is really starting to meld those two things together to make sure that we can have more real-time feedback and making sure that how we are impacting the clinical process is more real-time feedback rather than kind of a delayed process of 6 weeks kind of after the fact. And I don't really have an opportunity to improve upon it right at that point. So that's become really important to us. We've also had very little, we're trying to introduce more bot technology to help in minimizing some of the kind of upfront, the automation work that is sometimes very repetitive, that we can improve upon our process a little bit, so that introducing more bot and AI early on into our process can kind of then gauge and have a better overall digital or even experience within the U.
So yeah, that you did mention one of the things you wrote about too was artificial intelligence, and I want to ask about that in a second. But I liked what you said about if you're going to implement something that might make things better for the patient, is that making it better for the clinician? Because a lot of times we hear, you can add a new tool, but a lot of these new tools, while they may help in one area, actually make things harder for the clinician, whether that's the physician, the nurse, or anyone in that process. And when we talk about burnout, that's such a big topic right now with personnel issues, and just so much is expected and needed from clinicians right now. What are some of the things you're doing with AI? Like, you don't necessarily have to mention specific vendors, but what are some tools that you're either using or looking at using that can help alleviate some of that burnout and make things easier for clinicians so that they can focus on doing their job of taking care of patients?
Yeah, I'll give you one example. We have just an amazing biomedical informatics group. And we have a team, kind of a group called Reimagining the EHR. And Dr. Ken Kawamoto chairs that, and I sit on it, and my CMIO sits on it, and several other people sit on it. But one of the things and goals of that group is to do exactly what you're talking about. So I just presented on this, so it's kind of top of mind. Dr. Kawamoto created a Smart on Fire app, which is called Disease Manager. And so Disease Manager works in conjunction with our Epic system to really minimize the number of steps it takes for a physician to treat a patient who has multiple comorbidities. So just, real high level, normally when you come into the hospital, if you had multiple disease conditions, the likelihood of that physician knowing and being able to act on all the various benchmark data is about 48%. So it's a 50-50 chance that if you had multiple conditions, like if you had heart disease and you had diabetes, to actually rely on some of the disease management benchmarks, it's, based on all the data that kind of gets thrown at the physician, it's a 50-50 chance that you would that they would be able to pull into that data set. What Ken and his team has actually created is a way to pull in the data points based on what are the conditions that patient is being treated for, and improve upon kind of the best practices into the actual record of while they're treating the patient. So now they're actually can see up to almost 80%, and we measured this. We've gone from, I think he measured about 24 clicks of kind of getting into and using best practices down to 4 clicks.
Oh,
and
wow.
So it's just, I mean, he has improved the process mainly because you're taking the conditions by which the patient has already been kind of being treated for. You're looking at best practices. So he's got some AI in the background that's pulling in the best practices from the various areas, and then presenting that real time so that the physician can say, yes, I'm going to utilize that or not, and then treating the patient appropriately. So it's, I mean, we've documented it. He's published on this, and that's really a huge physician satisfier. But it's also showing, a better treatment process for the patient. So that's his disease manager. He and his team have created almost 10 different apps, very similar to that. We have a lung cancer screening app that he's done that incorporates the same kind of information right into the record.
Wow, that's fascinating. And just, when you can combine better physician satisfaction with better outcomes, that's kind of the dream, I guess, right? That's the end goal.
Yeah, that's the goal.
So last thing I wanted to hit on, and one of the things you talked about was consumer and patient experience, which I guess we've been kind of talking about here. But you talk about at the University of Utah Health, we plan to build a new hospital of the future with smart room technology, guardian angel services, and real-time location services. When I see, of the future in there, it's kind of like that. I think it was Dan Nygren, we spoke with him. He was on the podcast, and he talked about, it's kind of Star Trek level stuff. If you could take a minute to talk about what does that hospital of the future look like? What kind of technologies are being utilized to, make that, as efficient and well working as possible?
Yeah. So in some ways, we've already done some of this. We have our Craig H. Nielsen Rehab Hospital, which, sad to say, it opens smack in the middle of COVID. So we didn't do all of the big, marketing hoopla. Mm-hmm. But part of that was being able, a smart hospital should enable the best process for the patient. So in the rehab hospital, we actually, the patient can control all elements of the room. They can, by voice command, or even if they don't have voice capability, a sip and puff kind of capability to, open the blinds, close the blinds, turn on the TV, call the nurse, call the elevator. And by being able to put the controls back to the patient, that gives them a greater sense of control over, their life and kind of the situation that they're in, and that now they actually can go home with some feeling that, they have, kind of control over their life. These are people, especially in the rehab hospital, that have had spinal cord injury, and we're trying to get them back to a level of care and that they can go home. And we do everything from like the Tetra skis, and actually we've been able to put people back on the ski slopes that are even on ventilators, and be able to give them a kind of a hope that they can enjoy life even with the injury that has occurred. Now, when you think about some of that, not all of that kind of technology needs to be in a an acute care hospital. But what we want to do, and we've got an approval to build a new campus out in West Valley in the Tooele area. Really a kind of an outreach area. It's kind of an underserved area. So we're going to look at things like, how do we have better translation services? How do we have better, with My Chart for Spanish is just the start, but how do we continue that into the care of the hospital itself? Having capabilities of, RTLS throughout the facility and a strong kind of distributed, a DAS, a distributed antenna system in the hospital helps in the location services and helps in being able to communicate real time what's going on with the patient and what's going on with the care. And, frankly, and this is my own personal opinion, you want to be in the hospital as short of a period of time as possible, right? Mm-hmm. I want to shorten the time. I want to give you the best experience as possible, but I don't want you to always think that you have to be a visitor to our hospital. But when you are, I want that to be as seamless as possible so that when you drive up, it's not a long, lengthy registration process, that you kind of have already incorporated that prior to your arrival, and that you are, kind of that very easy registration entry into the hospital, whether it's from a critical care level or whether it's from just a regular outpatient treatment level. And so those are all the things that we're incorporating into our design of the building. The building design too is very, I think, ergonomically respects the, kind of the mountain design. Yeah. So it's not just a kind of a square or rectangular building smack in the middle of a kind of a cornfield. It's very it flows with the whole kind of the layout of what we have here in Salt Lake City and Utah. So there's a lot of things that we're planning, a lot of things we've learned from the rehab hospital that have really taken us forward, incorporating more and more from some of our EPIC design and roadmap where we're going, that we will kind of tap into some of those features and functionality.
Well, that's exciting. That's really cool to hear, and it's fun to hear that what technology can do, how it can help us provide better care, get better care as patients, and it's exciting to hear that you're building that a hospital in an area that really needs it, right? That's going to serve a population that maybe didn't have access to as high quality care or even care in general. So that's awesome to hear. Well, I think we're about out of time. I don't know if there's anything else you wanted to add. Just to wrap things up.
Yeah. But thank you for all that you guys do for the industry, because it is very much needed, and it is kind of takes us to that next level of improving what we need to do to deliver health and care for our communities.
Well, thank you. I certainly appreciate it. I know everyone here at class appreciates that. We love what we do and hope we can make a difference in healthcare, and we appreciate everything, obviously, that you do for not only Salt Lake City but the state as a whole, and just in healthcare in general. So thank you.
Thanks.
Well, thank you, Donna, for joining us, for sharing your insights on leadership, on what's happening at the University of Utah, how you're implementing technology to improve care and move things forward. Just thanks for joining us, and thanks everyone for tuning in, for listening. You can find the podcast anywhere you can find where you find your podcast. So look up Class Research, and also check out our YouTube channel for this video, for other videos in this podcast series and other videos that we've done to highlight what's happening in the HIT world. So thanks again for tuning in.